So they said. Here we go.
Should we open maybe to half stick? So so you see, is it this? Where is this speaker? So you'll have to. So I can leave it. It's not. It's not happening. Speaking part. And the speaker is really long. Okay, so probably I should leave. So do you think you can stop? Like, do you think I can put all my stuff in the bag so that it's a little bit look? Okay, so do you think if I put all my stuff in the bag, it's more smooth? Yeah. Let me just say hi to Bob. Hello. So it's okay, yeah? I can do this. Yeah, I just double checked that it's okay for me to leave when the speaker will come. Right? Yeah. I just put all my stuff in the bag. Yeah, it's good. So I just put like all my stuff in the back seat so it wouldn't look that actually. So I'm just like grabbing my iPad and like smoothly. Okay.
Shabbat Shalom.
Shabbat Shalom.
Good Shabbos, everybody. Can you hear me?
Shabbat
Shabbat
Shalom.
Shabbat Shalom.
Shabbat Shalom. Shabbat, 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 Shabbat Shalom. Shabbat Shalom. Shabbat Shalom. Shabbat, 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 Shabbat Shalom.
Is my microphone on?
Doesn't sound like it.
Doesn't sound like it. Will someone turn my microphone on, please?
Howie
That
to
way
the rest.
everybody will be able to hear me. All right, almost done. And God said, let there be a microphone. And there was a microphone. Thank you very much, Howard Felwissa. Once again, Shabbat Shalom to you all. Welcome.
Shabbat Shalom.
I am excited to be leading services, of course, with our amazing soloist, Beth, and also our wonderful accompanist, Guzal, who is apparently playing an opera this weekend. Yeah, we all like opera here. You should tell us all about it if there are still tickets available.
Oh, yes.
Yeah?
It's a Spanish opera by Daniel Catan. It's called Florence and an Amazonas. And it will be performed in the University of Maryland on Saturday.
Can you hear?
tomorrow.
At the University of Maryland, Clarice Smith Center for the Arts,
Yes. K Theater.
K Theater,
It starts tomorrow.
starts tomorrow.
And next week there are 3 shows.
Ooh.
One on Wednesday, another one on Friday. It's all evening time, 7:30 p.m.
And there are still tickets available.
The rest of
There's still ticket, and it's Florencia en las Amazonas.
and then Amazonas. Yes.
Ooh. All right, so for those of you that are opera buffs and you want to support Guzal, that's something that you can do Motzei Shabbat or this week. And I am also not just excited for leading services and for the opera, but also that this is our first Friday night event for Sinai and Synapses, scientists in the synagogues. And so this evening, we are going to have a very shortened service so that Dr. David Strouse and I can present you. Dr. David Strouse is the amazing son of Darla Strouse. If you have not met him yet, she's been busy. And Jim. And Jim. It does take 2 to tango. Actually, I'm not so sure. Well, anyway, so if you have not met Dr. Strouse yet, he will be up here and you will get to meet him up here. But I know Darla and Jim will be really excited to introduce you after services. We'll be presenting a session on the ethics of saving a life. But let's begin our service on page 20 with a welcome to the Shabbat bride.
Lecha dodi likrat kala pnei Shabbat nekabla Lecha dodi likrat kala pnei Shabbat nekabla Shabbat Shalom, Shabbat Shalom, Shabbat Shalom umevorach. Shabbat Shalom, Shabbat Shalom, Shabbat Shalom umevorach. Lecha dodi likrat kala pnei Shabbat nekabla Lecha dodi likrat kala nekabla, nekabla.
It's my honor to invite our congregant Terry Clayman to lead us in the lighting of Shabbat lights, page 3 and page 2.
As these Shabbat candles give light to all who behold them, so may we, by our lives, give light to all who behold us. As their brightness reminds us of the generations of Israel who have kindled light, so may we in our own day be among those who kindle light. Baruch atah Adonai Eloheinu melech haolam asher kiddushanu b'mitzvotav v'tzivanu lahadlik ner shel Shabbat.
Amen.
Blessed are you, Adonai our God, sovereign of the universe, who hallows us with mitzvot, commanding us to kindle the light of Shabbat.
Baruch atah Adonai Eloheinu melech haolam asher kiddushanu b'mitzvotav v'tzivanu lahadlik ner shel Shabbat.
It has become our Beit Aviv custom to take a moment in the service to greet each other, to specifically introduce ourselves to a people we don't know, wish them Shabbat Shalom, and it's okay if you've forgotten someone's name to ask again, because, hey, you know those little pixels in our head, they're, you know. So please take a moment to greet each other, Shabbat Shalom, say hi.
Shabbat Shalom. Tell me your name.
Sandra.
Stephen Sandra. Okay, nice to see you. How are you, Shabbat Shalom? How are you?
We sit in the front, right?
Yeah, well, I'm probably going to come and sit during the speaker because I don't have I'll come and sit next to you, Bob, for the speaker. Because I'll come in here. Be part of the audience. Shabbat Shalom. Shabbat Shalom. Shabbat Shalom. How are you? Hi. What's your name? Susan. Okay. Sorry if I remember that. Right? Yeah. Cal. And you're Roseanne. Hi. Yeah. How are you? I'm fine, thank you. I'm just covering my mic.
We continue our service on page 26. Please turn to page 26.
Yitkadal veyitkadash shemei Rabba.
Amen.
Ve'alma divrach yutei v'yamlich malchutei
B'chayechon uvyomechon uchayei techol Beit Yisrael.
Bagala uvizman kariv ve'imeru.
Amen. Yehi Shmei Rabba mevorach le'alam alal me'amaya yitbarach.
Yitbarach ve'yishtabach ve'yitpar ve'yitramam ve'yitnaseh ve'yitadar ve'yitaleh ve'yitalal shemei dekusham
Brichu.
leila min kol bechata v'shirata
Tushbechata v'nechemata damiran be'alma.
Ve'imeru. Amen.
We rise in our soul or physically for the Barahu found on page 28.
Baruch hu et Adonai hamevorach. Baruch Adonai hamevorach leolam vaed.
We read together at the top of page 31. Praise to you, Adonai our God, from whom the evening flows. Your wisdom sets the way on which time and season glide. Your breath guides the sail of the stars. Creator of the tide of time and light, you guide the current of day into night. As heaven spans to infinity, you set its course for eternity. Praise to you, Adonai our God, from whom the evening flows. Baruch atah Adonai, Hama'ariv Aravim. Responsively on page 33. Wisdom and wonder, passion and instruction, story and symbol. And the more we devote ourselves to it, the more it grows and gives. Then this holiest of your works and the living language that gives it form. Baruch atah Adonai, Ohev Amo Yisrael.
Shema Yisrael, Adonai Eloheinu, Adonai Echad. Baruch Shem Kevod Malchuto Leolam Vaed.
Please be seated. Page 36.
Ve'ata et Adonai Elohecha b'chol levavcha u'b'chol nafshecha u'b'chol meodecha ve'hayu hadvarim ha'ele asher anochi mitzavecha hayom al levavecha v'shinantam levanecha v'dibarta bam v'shivtecha b'veitecha u'v'lechtecha b'derech u'shokbecha u'v'kumecha u'kshartam leot al yadecha v'hayu l'totafot bein einecha u'chtavtam al mezuzot beitecha u'visharecha למען תזכרו ועשיתם את כל מצוותיי והייתם קדושים אלוהיכם אני אדוני אלוהיכם אשר הוצאתי אתכם מארץ מצרים להיות לכם לאלוהים אני Adonai Elohechem.
Adonai Elohechem Emet. Page 41 and 40. Sing the song of men and women joined in understanding and respect. The song of God's miracles, an earth protected and cherished, a gift for our children and the generations to come. The song of a land once ravished by war, now quiet and content, the soldiers home to leave no more. The song of a world redeemed, the song of peace.
Moshe uMiriam Zeli Anu ve'amru Adonai Melech leolam va'ed Adonai Melech leolam va'ed Adonai Melech leolam va'ed leolam va'ed.
Page 43. Let's read together. Let there be love and understanding among us. Let peace and friendship be our shelter from life's storms. Adonai, help us to walk with good companions, to live with hope in our hearts and eternity in our thoughts, that we may lie down in peace and rise up waiting to do your will. Baruch atah Adonai, הפורס סוכת שלום עלינו ועל כל עמו ישראל ועל ירושלים. We rise for the Amidah, page 46.
Adonai sifatai tiftach ufi yagid tehillatcha. Eternal God, open up my lips, that my mouth may declare your praise. Baruch atah Adonai, Eloheinu, v'Elohei Avotenu, v'Imotenu, Elohei Abraham, Elohei Yitzhak, v'Elohei Yaakov, Elohei Sarah, Elohei Rivka, Elohei Rachel, v'Elohei Leah, Ha'el Hagadol, Hagibor v'Hanora, El Elyon, Gomer Chasadim Tovim, V'Konei HaKol, V'Zocher Hasei Avot v'Imahot, U'Mevi Geula Livnei V'neihem, Lema'an Shemo v'Ahava, Melech Ozer u'Moshia u'Magen, Baruch atah Adonai, Magen, Avraham v'Ezrat Sarah. Atah Gibur le'olam Adonai, Mechayei hakol atah Rav le'Hoshia, Mashiv haruach u'morid hagashem, Mechalkel chayim bechesed, Mechayei hakol berachamim rabim, Somech noflim v'rofeh cholim, U'matir asurim, U'mekayem emunato, Lishenei afar, Michamocha ba'al gevurot, U'mido melach, Melech memit u'mechayeh, U'matmiach Yeshua, V'ne'eman atah, L'chayot hakol, Baruch atah Adonai, Mechayeh hakol. Atah kadosh v'shimcha kadosh, U'kedoshim b'chol yom yehalalu chasela, Baruch atah Adonai, Ha'el HaKadosh.
In some synagogues, it is the custom, once you have finished the Kedusha of the Amidah, to continue the rest of the prayer silently through Oseh Shalom, which is found on page 62. I invite you to concentrate on one prayer or read through all of them till page 62. And when you have finished your prayer, please take your seat. page 62.
Say shalom, shalom imromav, hu ya'aseh shalom aleinu, ve'al kol Yisrael, ve'imru amen. Hu ya'aseh shalom aleinu ve'al kol Yisrael. Amen. Oh, say shalom, shalom imromav, hu ya'aseh shalom aleinu, ve'al kol Yisrael, ve'imru amen. Ve'al kol Yisrael, amen.
Our hearts turn to those in our friendship, our family, our community circles who are in need of healing. We turn to page 253 for our Mishaberach.
Mishaberach avotenu mekor habracha limotenu. May the source of strength, who blessed the ones before us, help us find the courage to make our lives a blessing, and let us say, Amen.
On this Shabbat, our prayers of healing, our prayers of hope go out to Margot Joseph, Honey Kurlander, Joel Broider, Gail Broider, Eileen Kramer, Leon Shabtai, Jane Traub, Gloria Cohen, Michael Schonfeld, Chaya Bat Tzvia, Brian Brown, Christy Kuhn, and Ellen Levitt. If you have a name that you wish to share with community so that we can pray for them, and the name of your beloved one is one that you have been given permission to share, I invite you to do so as my hand meets your gaze.
Mishaberach imotenu mekor habracha lavotenu. Bless those in need
we rise for the Aleinu on page 282.
עלינו לשבח לאדון הכל, לתת גדולה ליוצר בראשית, שלא עשנו כגויי הארצות, ולא שמנו כמשפחות האדמה, שלא שם חלקנו כהם, וגורלנו ככל המונם. ואנחנו קוראים ומשתחווים ומודים לפני מלך מלכי המלכים הקדוש ברוך הוא.
Please be seated. We continue on page 287.
ונאמר והיה אדוני למלך על כל הארץ ביום ההוא יהיה אדוני אחד ושמו אחד.
Page 289. The light of life is a finite flame. Like the Shabbat candles, life is kindled. It burns, it glows, it is radiant with warmth and beauty, but soon it fades. Its substance is consumed, and it is no more. In light we see, in light we are seen. The flames dance and our life burns down and gutters. There is an end to the flames. We see no more, and we are no more seen. Yet we do not despair, for we are more than a memory slowly fading into the darkness. With our lives we give life. Something of us can never die. We move in the eternal cycle of darkness and death, of light and life. On this Shabbat, our hearts go out to Marsha Berlin and her family on the recent death of her husband and our dear friend and congregant Alan Berlin. We think of Eric Chait, who also passed away this week, and I am still in the year remembrance for my father, Peter Joseph. And we remember the following whose yortzites occur at this time: Marilyn Badolato, Isabel Bellman, Max Cohen, Beatrice Feinstein, Paul Ginsberg, Abraham Goldberg, Ruth Friedberg Gottlieb, Marjorie Koch Adams, Judy Lasov, Barry Owen Lipov, Alvin Lowe, Rose Massia, Sherry Anfang Puro, Janet Portney Reines, Fanny Ballo Rudnick, Norman Philip Schreibfeder, Evelyn Siegel, Abe Shapiro, Rhoda Berensinger, Evelyn Solomon, and Gladys Weisbord. Since we have so many visitors with us this evening, is there anybody else here remembering someone for Kaddish? Yes. The words to Kaddish Yatom, the mourner's Kaddish, are found on page 294. Please rise. Yitgadal v'yikadash shmei Rabba, v'yalmad yivrach hirutei v'yamlich malchutei, v'chayechon v'yomechon, ובחיי דכל בית ישראל, בגלה ובזמן קריב ואמרו אמן. יהי שמי רבה מברך לעולם עולמי עלמיה. יתברך וישתבח ויפאר ויתרומם ויתנשא. ויתהדר ויתעלה ויתהלל שמי דקודשה בריחו. לעילה מן כל ברכתה ושירתה, תשבחתה ונחמתה, דמירן בעלמה ואמרו אמן. יהי שלמה רבה מן שמיה, וחיים עלינו ועל כל ישראל ואמרו אמן. עושה שלום מממה, הוא יעשה שלום עלינו ועל כל ישראל ואמרו אמן. Zichronam livracha. May each of their memories be for a blessing, and we say, Amen. Please be seated. I'd like to invite one of our vice presidents of the congregation, Darla Strouse, to share with us our weekly announcements.
So I am going to be very brief, no jokes, no funny stuff. Shabbat Shalom, everyone. And so everything I'm saying is in the program if you've gotten your program, and in what's new. So, you know, if it's all going too quickly, just look that back up on your email. April 14th from 1 to 3 p.m., Bet Aviv's Day of Giving at OMI, and this is sponsored by the Women of Bet Aviv. Terry Clayman knows everything if you have any questions. The goods that are being collected are going to the Grassroots Day Resource Center and for Camp Attaway. On April 17th, 6 o'clock, there's Dinner with Divinity. This is the last one of the programs at OMI, room 200. I think it's 200. Yep. Final session is looking at a common theme of Passover and Easter, and that common theme is the theme of counting. So it should be pretty interesting. I hope you'll all come. April 18th, from 5 to 7, the Women of Bet Aviv's Women's Seder. And Jim wants to come to that Seder. I told him he could not come. This is at OMI in room 200. The Seder's being led by Rabbi Joseph. You should be registering if you're coming, so if you haven't registered, please contact Hattie Catcow. April 26th, another Shabbat abbreviated service and a Scientists in the Synagogue program, this time featuring our own member, Terry Clayman. Dr. Clayman was a pharmacist for many, many years. She's retired, but she and Rabbi Joseph are going to be discussing possible dangers in mixing over-the-counter drugs with prescription drugs. So that's going to be very interesting. April 29th is a Pesach Yisker, and we have this every year from 10 to 11:30 in OMI room 400. And finally, my final one is the men's drop-in lunch, and that is on May the 1st, starts at 11:30. It's at the corner stable for all the men who enjoy that lunch, which is very, very nice, in King's Contrivance Village Center. And that's it for me. They can't believe it. Really.
One other item, she was going so fast, she left one out. April 23rd, Tuesday night from 5:30 to 7:30, we have second night Seder with Rabbi Joseph on Zoom. A link went out, I think this afternoon, from Linda. So we're asking you to register so we have some idea of how many people will attend and to indicate whether or not you'd be willing to read one or more passages during the service.
Thank you so much, Lou. And thank you, Darla, as well. Our final song, because we are about to study some Torah together, is in the program. It is a song with the blessing for studying Torah by Dan Nichols. Please feel free to sing along with us as we use this as a transition into our program.
I would love for you to sing along with me, Sweet as Honey. It starts a little bit high, sweet as, but I'm going to invite those of you who are more comfortable singing down the octave, sweet as honey. You'll be singing it there, okay? Can I hear it back? Sweet as honey, good. Sweet as honey, sweet as honey on our tongue. Yes, okay, that's your part. Here we go. Sweet as honey, sweet as honey, sweet as honey on our tongue. Sweet as honey, sweet as honey, sweet as honey on our tongue. Baruch atah Adonai Eloheinu melech haolam asher kiddushanu b'mitzvotav v'tzivanu la'asok b'divrei Torah, la'asok b'divrei Torah. Here we go. Sweet as honey, sweet as honey, sweet as honey on our tongue. Sweet as honey, sweet as honey, sweet as honey on our tongue.
To begin our program this evening, I'm going to invite our Vice President, Dr. Darla Strouse, and my team partner in our Scientists in Synagogues program to come and introduce me and to introduce her son, Dr. Strouse.
Well, to anyone who does not know Rabbi Joseph, we have some guests. We have relatives who are so excited that they're here. I'm going to make this very short. She is a fantastic rabbi, and her beautiful accent is Australian. People were saying, is she from Great Britain or where? And she is the best rabbi of all time. So everybody, a big applause for Rabbi Joseph. So I'm going to spend most of my time talking a little bit and letting you know a little bit about David Strouse. So first I want to welcome everybody, and we do have guests, and we have cousins of mine, first cousins, Jim's sister and brother-in-law, and of course the wonderful children who were my grandchildren and wife of David, my daughter-in-law. So let me get started. This, first of all, is the third in a series of science presentations that's funded by Sinai and Synapses, the grant that we received, through the John Templeton Foundation and the American Association for the Advancement of Science. I, again, want to welcome all the guests who are here, and I have tremendous nachas and pride in introducing our science presenter, who is Jim and my son. Jim, you're in this. There's no way you could not be included. David Strouse. And I'm thrilled to call attention to his family who is here, who joined us tonight. First of all, there's Miriam, who's Mimi Strouse, my daughter-in-law, and granddaughter Isabel, and son Jake, who came flying from college to be here in Virginia. So welcome. Dr. Strouse is a cardiologist and electrophysiologist. And for those who aren't sure, what is an electrophysiologist? He specializes in procedures to correct heart rhythm problems. He is chief of complex ablation at MedStar Washington Hospital Center and associate professor of medicine at Georgetown Hospital. Our third seminar, I think as Rabbi mentioned, is featuring both Dr. Strouse and Rabbi Linda Joseph in a presentation and discussion around the topic, the ethics of saving a life. And as you know, the way the grant was given to us and written, the rabbi has an important role because the rabbi is bringing in the various texts, et cetera, that relate to any of the science topics that we have. This presentation is the ethics of saving a life. And David is going to explain his field of electrophysiology. He's going to talk briefly about a few new developments designed to save lives. He'll present an interesting case study. And Rabbi Joseph will discuss through Jewish texts what is permissible, what is ethical in Judaism when it comes to life-saving techniques. Now we're going to have a Q&A available because there are people who may have some questions that will be using that microphone, that stand-up mic. We ask if you have a question to come forward because there are people streaming and then they can't see you or hear very well if you're in the back of the room asking a question. So we ask that you not be shy and come forward and use that microphone. So we hope you enjoy this informative Shabbat presentation, and I'm going to turn it back over to Rabbi Joseph.
So I'm going to do a little bit of tech stuff here. Hi, friends. And I'm going to bring up David's presentation. Yes. And ask David to come up and join me here on the bima, which literally means a stage, right? And he's going to start our presentation off. We've already said the blessing for studying Torah. Yes? And I'm inviting him to tell us a little bit about what he does, a little bit about some of the techniques that are out there, and I'm then going to respond to him with a different slide presentation. This way.
Okay,
That's back.
okay, that's forward.
Yep.
Okay, and this is the pointer.
Yes.
Gotcha.
And the
Okay.
pointer you just press on.
David took wine up just in case.
The pointer you press on this,
Got it.
and then
Okay.
when you let go of it.
Perfect, perfect. All right.
The red one.
All right, that's great. Okay, can everybody hear me? All right, great, perfect. All right, well, we actually, brings me back because I went to, when I was growing up, we came to the meeting house for services with Temple Isaiah back in the day. It was here, and I was in this very room. And I remember sitting in the back there waiting patiently for the Oneg Shabbat to happen. So soon enough, I promise. Won't be too long. Okay, so in the next 15 or 20 minutes, I hope to kind of talk to you a little bit about some of the things that I do and then frame it in a context of ethics, because a lot of what we do in medicine is thinking about ethics and in particularly thinking about what is the right thing to do, and I think it kind of raises some important questions. And a lot of times when I give lectures like this, I give them to medical students. And when we were getting everything set up, my mom was saying, "Gee, do you think there's too far away from the front? There should be more seats up here." And I said, "Well, I'm kind of used to it because when I give lectures to the interns and residents, they all sit in the back because they're worried I'm going to call on them and ask them tough questions. So you all are safe here. It's going to be no problem." When I do give lectures, a lot of times there's a very specific way we do it, and we often talk about patients because at the end of the day, as clinicians, as we're taking care of patients, we're always thinking about patients. And I'm going to present a patient of mine who I saw in the office just this week, and I'm going to ask us all to think about this patient and think about it in the construct of what would you do. My grandfather used to always say that he went to doctors so often that he was a shtickle doctor, which means a little bit of a doctor. So today, all of us, with all of our education, we're going to be that shtickle doctor, and we're going to work together to kind of think about this patient and think about what you would do for the patient and think about it from this ethical construct. Okay, you all with me? All right, perfect. Okay, so this is this lovely patient. She's 92 years old, and for 92, she's what we would say a young 92. She lives independently. She lives in her home of 50 years, and she does everything on her own. She cooks her own meals. She's very active with her synagogue and her sisterhood, and she loves to garden, and she's been very active like this her whole life. And she really has had been blessed by having very few medical problems. She has only a history of hypertension, and for which she was just taking a very low dose of an ACE inhibitor, lisinopril. And she presented to the emergency room with her, what we call sentinel episode of syncope, her first episode of a passing out spell. And at the time when we went to talk to her, she described the episode as being very upsetting. Obviously, she had never had this before. And the episode occurred in the morning. She was fixing some breakfast for herself before she went to the synagogue for a sisterhood meeting. And she had what she described as an abrupt loss of consciousness. And what we're always interested in a lot in medicine is the history. The history is really important to help us understand. And what she described in the moments beforehand was a relatively abrupt loss of consciousness. She didn't have a lot of warning to kind of get herself to a safe place. When I asked her if she felt any symptoms of palpitation, she described some symptoms of some fast heartbeats right before it happened, with a loss of consciousness. And she said that she had felt palpitations before, but she had never lost consciousness before. That was very unique for her. On physical examination, pretty unremarkable for 92. She had normal heart sounds. Her lungs were clear. We were monitoring all sorts of things while she was in the emergency room. We noticed several things. One is at one point, she was on a monitor on telemetry, so we were watching her heart rates all the time. And we saw at one point that she went to the bathroom, and when she got up to go to the bathroom, she didn't really have much of a very high heart rate. She's not on any medicines to slow her heart rate, but her heart rate was really in the 40s. And she said, gee, I feel a little bit tired. I feel like this sometimes when I'm gardening. I don't feel like I have as much energy when I'm doing things. But she never really thought to mention it to her doctor in the past. We also noted the following day that on the monitor we saw some fast heartbeats in the lower chamber. So she had some slow heartbeats that we noticed in the upper chamber. It's called sinus bradycardia. And then she had some fast heartbeats in the lower chamber. Not that many, about 6 of them. And she said maybe she felt some palpitation with that, but she really kind of ignored it. It didn't really mean very much to her, but she might have felt that. Laboratory tests were really unremarkable. 92, doing pretty well. Kidney function is normal. She does not have any evidence of anemia. But when we did an echocardiogram, an ultrasound of the heart muscle to look at the structure, we saw that the heart muscle, surprisingly, was significantly weakened. Her ejection fraction, which is a measure of how the heart squeezes, was about half or about a third as good as we might expect it to be. Ejection fraction should be around 55 to 60%, and here you can see it was 20%, so markedly diminished. And it looked like on the echocardiogram that there was some structural differences, that the heart squeezed in a different way, suggesting that maybe somewhere along the way she may have had some type of a silent heart attack. But 92 years old, she never sought evaluation, and that's the kind of information that we have. So based on that information, 92-year-old patient, weakened heart muscle, having an episode that frightened her, scared her, a sudden loss of consciousness. She has some things that we are identifying that seem a little unusual. Her heart rates are a little slower when she's getting up to do things, maybe some symptoms of palpitation. How do we think about this, of what we should do next? Because a therapeutic procedure was done. So the question is, what is the therapeutic procedure? What would you do if you were the doctor there seeing her for the first time? Okay? So that's what I want you to kind of think in the back of your mind as we go forward. Everyone with me? Yes. Okay. So we're going to talk a little bit about what an electrophysiologist does. And because this case hits on just about everything that we do in one form or another. So when I give this presentation to the medical students and the interns, this is something that they often will ask, well, what exactly do you do? And so I would say, what I thought to say is the electrophysiology service. What does the electrophysiology service? Well, there are 3 syllables, EPS, right? So E stands for ejection fraction less than 35%, a weakened heart muscle. P stands for palpitations, and S stands for syncope. So you can already see our 92-year-old patient is exhibiting each of these 3 things. This is 95% of the work where an electrophysiologist can help a patient in need. This is where we can come in helpful. So we're going to talk a little bit about why those are the 3 main things where we can be helpful. Well, let's see. Okay, so ejection fraction less than 35% means that the heart muscle is weakened. And the number of 35% is just a statistical number because in a number of clinical trials, when we showed that people with weakened heart muscles had an ejection fraction less than 35%, significantly more weakened than one might expect, those patients benefited from getting defibrillators. These are devices that are pacemakers, plus they can also protect folks from dangerous heart rhythms. You see, 400,000 people every year die suddenly, and that's called sudden cardiac death. And identifying the majority of those patients is very hard. But the tip of the iceberg, the ones that we're the most able to identify, the most risk, are the ones that have an ejection fraction less than 35%. That weakening of the heart muscle correlates very, very well with a greater risk of having dangerous heart rhythms. And multiple clinical trials have shown that. This is going all the way back to the 1980s, where we look at 2 populations of patients. And your idea, this is a survival curve. So what we're looking at here is CMT. This is standard medical therapy. And if you look at people with weakened heart muscles, this is their natural life expectancy over the next 3 to 4 or 5 years. That there is a significant, if their heart muscle is markedly weakened, less than 35%, the chance of dying is substantial, even if you give them really good medications. But in this population, if you also gave them a defibrillator, their mortality was better. People still died, but less of them died. There was a mortality difference. And in medicine, that's very rare. There are very few things we can do in medicine that have a mortality difference. And this was proven over and over again to have that mortality difference. So giving folks with a weakened heart muscle a defibrillator seems in that population of patients to make people live longer. But I ask you, we're thinking about this 92-year-old patient. She's 92 years old. Is that the right procedure? Her ejection fraction is low. Should we just give her a defibrillator? Maybe, but maybe not. Maybe that's not the right decision. She's 92. Maybe we shouldn't do such an invasive approach. Something to think about. This is what a defibrillator looks like. So it has wires here in the heart muscle. This is, you can see a wire here into the ventricle, in the right ventricle, and there's actually an additional wire into the left ventricle, because in some patients who have certain forms of conduction abnormalities, adding an additional lead to what's called biventricular pacing actually makes an additional benefit, additional mortality benefit, as well as a morbidity benefit. So their quality of life is better, and they even live a little longer in a certain population, a subset. Okay, so that's the ejection fraction less than 35, okay? The next one we're gonna talk about is the palpitation. And that's a lot of the work that we do. There are a lot of folks who come in to see us who just feel fast and rapid heartbeats. And it's our job to kind of understand what that could be. Our patient had symptoms of palpitation. They didn't make her pass out as far as we could tell, but she had them. Maybe there's something related in this 92-year-old. Well, what is, how do we evaluate palpitation? Well, I'm gonna show you some tracings of a patient who had palpitation, who had a weakened heart muscle, who had had a heart attack, who had a documented arrhythmia, and this was an ablation procedure that I did just the other day. So what you're looking at here now is an illustration of the heart muscle. So what we're able to do is we're able to create a 3-dimensional reconstruction of the heart muscle. So this image here is of the body. So this is the orientation of the left ventricle, and here this is the aorta. So what we're able to do is create a 3-dimensional structure and actually as we move the catheters, we can see wires inside of the heart muscle in real time. So in real time, we're looking at the electrical system of the heart, and we're looking at wires inside of the heart muscle. This actually came all out of Israel, because in Israel, during times of war, they were very worried and wanted to understand where tanks were in three-dimensional space. And this came out of the time of the Lebanese, the war in Lebanon, and they wanted to be able to figure out where formations of tanks were. And after that war concluded, they thought, the military said, well, what are the applications? And they said, well, why don't we use it for medicine? And that's actually true. It's called Biosense Webster, and it's one of the main companies we use to look at things. So what are you looking at here? You're looking at a lot of squiggles, a lot of electrical signals. And what these are really defined electrical signals of what's going on in the heart where the catheters are sitting. So what you're looking at is in the ventricle, and what you're looking at is an image of the patient in clinical tachycardia. So what you're looking at is a lot of electrical activity, and where you see a lot of what we call this crowding, where you guys see that there's a lot of there's a lot of color right here in this very center. That's because there's a lot of electrical things happening right there. So out further away, there's not much electrical things happening. Here, there's a lot of electrical activity occurring in that narrow space. And that's an area that we're really interested in, because that often is where the tachycardia is coming from. And this is just another image now looking at the voltage. And you can see that this gray area here is an area of scar. So there's no electrical signal there. This is where this patient had a heart attack. And when you put all that together and you're looking at the ventricular tachycardia, this is the scar, and this is all this area of electrical excitability. And that's where we are going to focus our attention. What you can actually see in tachycardia is the electrical signals moving through the tachycardia. So here are what we call vectors of electrical signals, and you can see the vectors are going through this area. And we can actually animate that for you. So you can see the signals now going through that scar, right? Can you all see that? So this is this patient, we just did this ablation 2 days ago of a patient with VT going through an area of scar from a heart attack. Is this what our patient has at 92? She had palpitation, she's had scar in her heart muscle, we think. Did she have the same type of arrhythmia? Should we do this electrophysiology study on her or not? And then what you can see here is another resonance. So you can see the electrical signal going through that and wrapping around. This is what we call a figure of 8 reentry tachycardia. And what you can see, this is now a catheter here where we're burning. We're going to burn right in that area. This is what we call the narrow isthmus. This is the critical part where the tachycardia occurs. And you can see we gave a bunch of lesions there. And when we did that, then the patient had no more tachycardia. So that's called a ventricular tachycardia ablation. And this is really kind of the cutting edge of things that we can do for people with very potentially dangerous rhythms that are very symptomatic. Okay, so the S stands for syncope. Let's talk about syncope. Our patient came in with syncope. Well, I will tell you that syncope is a really common reason that we're called. A lot of times, the folks who come in with syncope, they end up getting this enormous neurologic workup. And there's a neurologic evaluation, there's brain scans and MRIs and electroencephalograms. But unless somebody has a really classic history of brain problems, being hit on the head trauma, things like that, the likelihood that our 92-year-old patient had a seizure is remarkably low. It's almost always something related to the heart. And in fact, syncope is extraordinarily common. If you look at patients over the age of 75, about 75 to 80% of them will have had one episode of syncope. And of that population of patients, 95% of them never have another one. So it's a common diagnosis and often hard to tease out.
What is syncope?
Syncope is passing out, so or falling out. Some people will say. So where you abruptly have abrupt loss of consciousness. That's great. Any other questions? All right. Okay. Well, let's talk about the most common reason that people pass out. And the most common reason people pass out is what we call vasovagal syncope or neurocardiogenic syncope. And the reason for that is that we're not giraffes. So we're the only mammals that stand upright. And the reason for that is that the force of gravity is extremely hard to contend with. So the blood in your body wants to pool in your legs, And your body has to do all sorts of machinations to keep the blood going back to your brain. Because you see, your brain doesn't care if you're standing upright or sitting, lying flat or upside down. It wants exactly the same blood flow. So it has to do all sorts of things constantly to regulate. And it's amazing to me that we all don't pass out every single time we get up. And a giraffe actually has such incredible neck musculature that it can bend down from the ground and go up to 27 feet above ground in a matter of seconds and never lose consciousness. But the musculature allows it to compress the blood so the blood flow to the brain is the same. That's the most common reason for people passing out. And this gentleman here is in one of the guards. I forgot what are the people on Buckingham Palace who have the big hat? Yeah. So if you've ever been there, you'll notice that they stand very still and they won't move. Well, this gentleman had a history of passing out, and he's standing in here for a procession for Queen Elizabeth, I believe. This is a number of years ago. And if you ever look on YouTube or this video, look for the beefeater passing out, what you'll see is that they were so attuned to standing straight. You could see him, and you could see him starting to wobble, and he falls down, and all the other beefeaters don't pay any attention. They just keep standing straight until somebody comes and attends to this guy. He had a common form of faint. He had neurocardiogenic syncope. He was a little dehydrated, and he was fine. Did our patient have this? 92 years old, early in the morning, she's fixing herself some breakfast. Maybe she was a little dehydrated. Maybe that's the common faint is the whole explanation for her episode of syncope. It could be any one of those three things. So we think about our patient. She has an ejection fraction that's low, less than 35%. Should we give her a defibrillator? She has palpitations. Maybe palpitations was enough to give her the passing out, the falling out episode, the syncope. Maybe we should do an electrophysiology study and maybe an ablation procedure like I showed you in that other patient. Or maybe she just has the common form of faint. Or maybe it's the slow heartbeats that we saw that she had. Maybe that's the root cause. We're left with those questions. And a therapeutic procedure is performed. So your question now you have to say, what would you do if you were in my shoes? All right. And with that, I'm going to thank you. Thank you very much. So now we'll have Dr. Joseph.
All right, a little bit of change here in our So, the ethics of saving a life. What does Judaism have to say about all of this? Because as Reformed Jews, or if our visitors of Jews, whatever flavor you are, one of the things that we're taught is that we should give our law, our tradition, a vote, but we don't necessarily have to follow it if we're Reformed Jews. We can veto it if we don't understand it. But if we're making decisions as Jews, we should understand what Jewish tradition has to say. So Yeah, this is the problem. Let me get rid of you. Let's go to this slide. Will it help me do that? Nope. Don't we love it when technology is not working the way we want it to? Let's try this again. Escape. F8. Won't move. Let's shut it down. All right, let's try this again. It's because I had two things up. Excuse me. So now I'll go to see my filing system. For some reason, it wouldn't open there. Huh? I lie? There we go. I've had this sort of week, my friends.
I'm having syncope right now.
Yeah. There we go. Woohoo! All right. So what is the Jewish case for saving a life? Here is the same case that Dr. David Strouse presented with us, 92-year-old woman. She presents to the ER. We have history, all her history, the scientific stuffs, and we were explained in greater detail what the options were. So my job, if I'm trying to reach out and think about what are the ethics of this, is to say, is this case similar to any other case that Jewish law has ruled on? Has there been somebody of elderly age that needs a procedure that may or may not be the best choice for them? And so I went looking through my books of responsa and pulled out this beautiful one here that's old and a bit tattered, but still good with its contents, called Contemporary American Reform Responsa, edited by Walter Jacobs, who used to be the chair of the Central Conference of American Rabbis Responsa Committee. Now, what is responsa? Responsa, or teshuvot in Hebrew, is when somebody, a rabbi or a person just like you, wants an answer to a Jewish question. So they'll write to a series of rabbis who will research that question and then will present their research and the possible answer or opinion on that question, right? So when you have a responsa, they go through all the different sources. And in this book, I found this question from some rabbi in Illinois, unidentified. And what does it say? It says, a 96-year-old woman who lives in a nursing home has recently been informed that severe hardening of the arteries necessitates the amputation of her foot. It's a different scenario, I know, right? But she needs some sort of help with a medical emergency. As a result of the shock of hearing the news, she's become severely disoriented. Her family was subsequently advised of her situation, and several alternatives were presented. So much like our 92-year-old patient, right, this woman needs some sort of medical intervention, and there are several alternatives that are offered. She may submit to amputation with a chance that her condition will be permanently corrected. However, there's no assurance that she may not die during surgery or soon thereafter, right? Is there danger? Is there not danger in surgery? Furthermore, her other foot may be similarly affected, or her rehabilitation may not be successful. The alternate is a slow and painful death, which can be partially relieved by sedation. The family wants the mother to make the decision. She refuses to sign the release for surgery. But as her lucid moments are brief, it's not clear whether that is what she actually wishes. Should there be surgery, or should matters simply be allowed to take their course? Now, this is a different situation. However, when I read that, I was like, it's going to take me through the ethics of when to do surgery and when not to do surgery. What does Jewish law have to say on that? So, here are our commonalities. We have elderly patients, 92 years old, 96 years old. And surgery might be life-enhancing and life-saving, or will it? That's our big question. Is it better to do nothing, or is it better to do something for that person? So our first text is in the responsa that it brings from us is from Sanhedrin 23a. And rabbinic tradition from Talmudic times onward has encouraged the utilization of all possible medical procedures for life-threatening situations. Sanhedrin 23a advocates this direction on the basis of the following biblical verse in Leviticus. You shall not stand idly by the blood of your fellow. And also in the Talmud in Baba Kama 85a, it bases itself on he shall cause him to be thoroughly healed, which is a verse from Exodus. So it sounds like, just from the beginning of this responsa, that yes, in both cases, if surgery is going to help, it should happen. Nachmanides, who lived in the 13th century, in his commentary on Leviticus chapter 25, verse 36, and your brother shall live with you, agreed with this. He followed this path, which was earlier proposed by Chai Gaon in the 10th century. So now we can see this is not just in the Talmud, but even later commentators believe that if there is surgery that is going to help, or medicines that are going to help, or some sort of intervention that's going to help, yay, do it. Yehuda Lev Zilson, who lives in the 20th century, applied this line of reasoning to less dangerous, non-threatening situations, right? So even if what you have is a minor ailment, it is permissible to do the intervention. So the majority opinion is thumbs up, do it, right? Medical intervention should be used. But we have an elephant in our room. He has giraffes, I have elephants. All right? The elephant in our room is when somebody reaches the age of 92 or 96, which is getting up there. I know some of you are closer to that, but it is. I'm sorry if I've upset you. It's getting up there. We have to ask the question, is surgery a risk, right? That's the elephant in the room. And then a further question we should ask from Jewish tradition is there an age limit beyond which tradition would not advocate medical intervention? Does there come a time when you're so close to that period of perhaps dying that you should just let it be? And another question we need to ask is, will this prolong her life, it's her in both these cases, in a meaningful way? And should it matter, right? Should quality of life matter? Is that something we should take into account? What will the quality of life be? So that leads me to another text, which is from the Talmud, from Avodah Zarah 27b. And the text is on our left. Where the bold lettering is, that's what's actually written, the translation of what's in the Talmud. And the material that is not bold are the rabbi's commentary, if you like, on that section in the Talmud, how they understand the passage. The Gemara asks, and from where do you say that we are not concerned with the value of temporal life? As it is written with regard to the discussion by 4 lepers outside a besieged city. If we say, we will enter into the city, then the famine is in the city, and we shall die there. And if we sit still here, we will also die. Now therefore come and let us fall unto the host of the Arameans. If they save us alive, we shall live, and if they kill us, we shall die. Quote from 2 Kings. The starving lepers decide to risk premature death rather than waiting to die of starvation. The Gemara asks rhetorically, but isn't their temporal life to be lost, in which case it would be preferable for the lepers to remain in their current location? Rather, is it not apparent that we are not concerned with the value of temporal life? Now, what has this got to do with our question? The Talmud uses this discussion to show that in life-threatening situations, one might place oneself even in the hand of idolaters. In other words, if somebody who you're not so sure and trusting of, right, can save your life, you are allowed to trust them for that. In modern times, because this passage is written in a larger discussion about medicine in the Talmudic times, this particular passage is cited in order to permit the use of drugs whose side effects might be hazardous, right? So we are allowed to undergo a procedure even if there is danger within that procedure. So there are further discussions about the use of hazardous drugs when the chance of survival is low. Eliezer Waldenberg feels that a 50% survival rate was necessary to recommend the risk. If there's 50% of a chance of recovery or a better life, do it. And others like Moshe Feinstein, who you may have heard because he writes a lot on medical matters, feels that that hazardous procedures and drugs may be used even when there is only a remote chance of survival. So let's just say there's a 5% chance of a survival or a 2% chance of survival. He says, go ahead, do it. Now, other people debate about this matter. It's quite clear, however, that the use of medical procedure, even with a high risk, has been encouraged by traditional Judaism whenever there might be an opportunity to save a life. But what about age? Is there an age limit beyond which this should be applied to? So in this response, they also say, let's have a discussion about when it's time to let go. We know what the traditional sources say, but in ancient times, or even in your parents' time, people weren't living to ages like 92, 96, 105, 108. That wasn't the regular, that was the exception, not the rule. If an individual is close to death, she should be permitted to die peacefully, and it's not necessary to subject them to needless pain through therapy, which cannot succeed. So the question is this going to be helpful, or has the person's time really come? And that's a judgment call, right? That's a judgment call of the doctor, it's a judgment call of the family. But, says Jewish tradition, if there is a chance for success, it should be undertaken. So you're weighing up again, is there a 50% chance, a 70% chance, 2% chance? Although the lifespan throughout the rabbinic and biblical period was low, the psalmist's ideal of 70 years and 10, or by reason of strength 80 years, and Moses' life of 120 with his eyes undimmed and his vigor unabated, as well as the ages of the patriarchs and others, point to the ideal of an advanced age. As medical practices advanced and made a longer life possible, we too should encourage medical procedures on individuals who've reached an advanced age. In other words, a response from our Jewish tradition is saying, you know, there's value to older life. A modern concern is the psychology of the patient. Rabbis are not quite so much concerned about psychology, but psychological factors are concerns in our day and age. So Dr. David Strouse already told us that this was an active patient, had a full life, gardening, cooking, right? Sisterhood. Thank you. Right? The chances of success of the surgery, what percentage would you put it at?
All of them would be very high.
All of them would be very high, so above 50%. More than that. 95%. It's a good percentage, right? Psychology of this patient, very happy with their life. Just a little concerned that they passed out while gardening, right? So what would the Jewish advice to the doctor be? What would Judaism say we should do in this case? Do it. Do it. Do it. So, what,
Okay.
so what?
So do it, huh? Do everything. Well, the truth is that what I've learned over the years is that, listening to patients is always the key, right? Because everyone has a different perspective. And you're absolutely right. Actually, in the medical literature, it's actually defined. So there are recommendations for example, giving a patient a defibrillator. And interestingly, if the patient meets clinical criteria, which means the ejection fraction less than 35%, and not any evidence that it's going to get better all of a sudden with good medication, so on optimal medical therapy, you can give them a defibrillator regardless of age, as long as you think they can live, you're expecting them to live more than a year. So anything more than a year, the consensus is that patient would be eligible for a defibrillator. She would have also been eligible for an ablation procedure to study her heart muscle as well. But in the end, what we did was we talked to her and we said, look, we can do all these sorts of things. You're 92, you've lived a long life, what would you like us to do? And I've often found that that's usually the key, because the folks are usually pretty thoughtful about things. And what she said was this. She said, look, I've lived a great life. I don't expect to live forever, but my quality of life is really important to me. And I'm able to do things. I'm able to live independently. I'm able to garden. And that was really what I want to be able to function and do. Anything you can do to kind of optimize my quality of life would be really of value to me. And so what we had documented was that she had bradycardia, slow heart rhythms, and she was symptomatic from that. And I think in retrospect, she has been probably symptomatic from that for a number of years. Additionally, a pacemaker, a very specific one version of it, can help with a common form of faint. And to be honest with you, I'm pretty sure that's what she had. I think it was just an unusual presentation of a very common faint. But this pacemaker could actually help with that as well. It has an algorithm to help with that specifically. And so what we decided to do, the therapeutic procedure, was we gave her a pacemaker, because we figured we could use that information to help maybe preventing her from passing out. We could help her quality of life so that she can be able to do gardening and do the things she really loves to do, but without necessarily doing more invasive and complex procedures, such as an invasive electrophysiologic study and a possible ablation. And that turned out that's what she actually wanted. And so we actually just saw her in the office this past Tuesday, and she actually feels much better. She has more energy when she's gardening. She hasn't passed out. She's been drinking lots of fluids, because that's actually the most important thing you can do for folks who have a tendency to dizziness, is to keep yourself really hydrated. So we've really focused on that for her, and that has made the difference.
So David, what would happen if you looked at a patient and everything you could do was much less of a chance to be helpful, right? That they might not get a year out of the pacemaker, or like, what sort of process do they go through in the hospital as you're talking about the ethics of it? I mean, clearly Jewish ethics says if there's a chance, do it.
Yeah.
But from a medical standpoint, from the ethics of medicine today, what do you discuss? Well, how do you weigh this up? Do you go to the patient and say, you might not live longer than 6 months, but let's try this anyway, or?
Well, in her case, I didn't think it was a mortality difference. I thought it was a symptomatic difference, and I thought we were going to help her clinically with the pacemaker, and we would also have a lot of more diagnostic information. So I think in the end, if we were to identify her to have sustained fast heart rhythms, and she's continuing to live her life, and we would explore doing an ablation procedure to try and fix those fast heart rhythms so that she wouldn't have those symptoms. She would be eligible for that. Or we could try medications. I mean, there's lots of different ways you can deal with fast heart rhythms other than an invasive, potential curative procedure. So different ways that you can approach it.
Any questions that people have? Lots of people here from the congregation.
Where is George Groman? He said he was going to ask a question. Where is that?
Okay, if people want to line up in the center, just so that we know that you want to ask a question. I know, now
Although
I'm
you're
worried,
not
the lawyer.
responsible for this, how does Medicare and insurance, what role does that play in this? And how do you deal with that? I'm going to stop there.
Well, it's interesting. So if you're in the hospital, then you can whatever you think medically is indicated is fine. If someone's an outpatient, we have had not so much with Medicare, but with private insurance, them saying, well, we don't think this is we're not going to approve it, to do an electrophysiology study. There's some of that, and then you have to talk to a medical person and say, look, this is why we need to do this test. This is indicated. So you have to have a conversation. But usually that's not an issue. For her, she was in the hospital, and pretty much they just tell you, to do whatever you think is clinically indicated. Uh-oh. Trouble.
Thank you very much. I was prodded by your mother to get up here. So I'm going to ask you a question that might be a somewhat different approach. In that, as you said, she met all the criteria for an ICD, and you as an electrophysiologist that has great experience with complex arrhythmias are thinking of an EP study to ablate that arrhythmia. What about a slightly different tack and follow the words of the late Michael Morawski, looking at sudden death as an event that many times is parallel to one's weakened heart function, and have placed a simple ICD with pacer support?
Yeah, we would have offered her that if she had wanted it. She actually declined it. She said, that at 92, that if it was her time, she didn't want that life-saving,
That makes a lot of sense.
Yeah.
Okay.
Anybody else with questions that wants to come to the microphone? Lou is coming up. And Maddie. Chris, yeah.
Beginning.
Yeah.
Doctor, what is an ablation? Is that a new procedure, relatively new? Because I worked in a hospital many years, and that's new to me. Can you explain that a little bit more?
Yeah, so
please?
What we do is, let's see, so you've heard of a heart catheterization, right?
Yes,
right.
I
So
have,
it looks
yes.
like that. You're on your patient's. Let me see if I have a picture of it, a cartoon.
Oh, Elvis. Oh.
Elvis is in there. Well, so in any case, you're on a table. We have imaging, all sorts of imaging paraphernalia in front of us, catheter, X-rays, and all sorts of digital equipment. What we do is we do the procedure from the upper thigh. There's a big vein there called the femoral vein, and we can go up
So
from
excuse
that.
me, is it something like the angiogram that they did?
Like an angiogram, but we're
'Cause
in the.
I had that done, but the ablation. I
Correct. Yeah, we work bring catheters up inside of the body to the heart muscle, which we can visualize
Right.
based on those the mapping. We can actually see the catheter inside the body in 3 dimensions, and we stimulate the heart, and we can characterize where these rhythms are coming from using all these specific catheters. So this technology really kind of evolved, as I mentioned, in the mid-1980s after the Israel war in Lebanon. They figured out how to use this technology and miniaturize it and create 3-dimensional constructs of the heart in the same way that they were looking at 3-dimensional tanks on a battlefield.
You
And
have
that
to have
technology advanced, as you can
you have
imagine,
to
over
have
the past
more,
30 years.
VTAC than a more worse heart condition.
So ventricular tachycardia is always a really hard one for us because those tachycardias are not well tolerated, and people get their blood pressure drops very low and it's unstable. The more common rhythm is actually atrial fibrillation. I don't know how many of you have heard of that word, but that's a pretty common
I know
one.
it well,
And it turns out atrial fibrillation is also ablatable, curable, with a catheter in the atrium.
but they usually put the pacemakers in? No.
Don't necessarily need a pacemaker. There's a very good chance that atrial fibrillation is curable. Probably about 85 to 90% of patients
But I
can
know
be
a lot
cured
of
of it.
people that did have pacemakers put in with that condition.
Sometimes pacemakers are utilized, but the idea would be to eliminate the tachycardia so that they don't need a pacemaker. Yeah, so you can do those same types of procedures, but looking at the top part of the heart muscle as well. That's actually much more common.
Okay, thank you.
Yeah.
This is my revenge. So, one of the disconnects between your presentation and the rabbi's is the rabbi was talking about instances where somebody's life was immediately in imminent danger of being extinguished. Yours wasn't really that case.
Yeah.
So to try to pull the two together, we all know of instances where we hear of either elderly people or very sick people who aren't qualified to get a new heart because of these various factors that are involved. And you made one reference to maybe if the procedure wasn't going to prolong somebody's life by more than a year, maybe it wouldn't get done. So I really see a big problem in bringing ethics into the decision to prolong a life, because maybe the life that you're prolonging is a life of somebody who's a real do-gooder, who brings joy and happiness to a great number of people every day that he or she lives, and does more good maybe in a month than another person who might be a thief, a murderer, who might be needing a new heart, but you prolong his life so that he can steal and rob and do harm. So I basically suggest that ethics really should be taken out of the decision-making process. You let the patient make the decision. If they're not capable of making the decision, then you go through the legal system to get somebody to be an attorney. I got to get a little business here for the attorneys. You get somebody on their behalf to make that decision.
So from a Jewish point of view, of course, right, we would say just do it anyway.
Right,
Because you
yeah.
never know, even if they've been evil in their life up to this point, there might be one mitzvah in the next
Right.
year,
No,
right?
I'm not suggesting don't give it to the bad guy. Unfortunately, there aren't enough hearts to go around, and some measure has to be instituted, I guess, how to decide how to give them out. But I just think it's real dangerous bringing ethics into this kind of process of saving a life.
But surely, I mean, David, you can answer this better. Surely there needs to be some sort of discussion on the ethics of whether to do something or not do something, and whether this is right for the patient, if it's right in terms of insurance and monies, if it's right in terms of a good use of doctors' times.
Well, I think, I think it speaks to what we would call informed consent, right? So the problem is, we'll see this a lot in other scenarios where somebody comes in and they've had some type of a calamitous thing. It's somebody's, it's their mom, it's their grandmother, it's et cetera, do everything. Right. Well, sometimes doing everything is there's a lot of pain involved. It's arterial lines, it's sticking things, it hurts to do these things. And so I think part of what we're obligated to do is to be able to say, look, you have to understand, if we do those things, and we can do them, we'll do them if you want, you have to understand that there is a cost to that, not a monetary cost, but a quality of life cost.
I don't think that's ethics, though. That's just part of the decision-making process.
I would say that's ethics, though,
Yeah.
right? You have to make an ethical choice of how aggressive to be.
But you're not
when you look in
making the
person's-
choice. The patient is listening to the information and making a decision based on the information you've provided to him or her.
I think that's ethics, though. I think that they're
Yeah.
making their ethical choice.
I think it's ethical to give the patient all of the information that they need. No, that's enough.
George and Sally, and then we'll wrap up so we can do kiddush.
So Lou's got me going as well. Dr. Strouse, you recognize that when you're in the intensive care unit and you see an 88-year-old person who's had, for instance, abdominal aortic aneurysm surgery. What I was saying was that I believe that Dr. Strouse has a lot of experience with critically ill people. And in the intensive care unit, as an example, and this is hypothetical, if one had a patient who had had an abdominal aortic aneurysm repair, who then became hypoxic and coded for whatever the reason, and ended up being markedly impaired mentally, and these are things that do happen all the time, the ethics does come into play because you have to be able to say to the family, realistically, even if Joe recovers, Joe will not be thinking very clearly. And it's not a question of cost to the system so much as it is a question of suffering of the individual. And we're not clairvoyant, but the ethics of having to present that to the patient's family is important.
Yeah, I mean, for example, actually, it was a patient today who came in. We were seeing in consultation, who had sudden cardiac death, 62 years old, and he is very sick, critically ill, and he's on a cooling protocol. Cognitive function is very questionable, and we were asked to comment about whether that patient should get a defibrillator. And the answer actually is that if the patient is not cognitively aware to understand what a defibrillator is and understand if the defibrillator fires and causes a shock, what that means, that it's actually contraindicated to put it in. Because then you're basically, you're doing things that just cause pain, and they don't cognitively understand why these things are happening. It's a class 4 indication. So you do need to have, there have to be some elements for it to be ethically reasonable to put it in, beyond just the technical part.
I think the informed consent is really critical.
Yeah.
My father and his sister both had hardening of the arteries. His sister chose not to have her foot amputated and died at 95 and a half. My father chose to have his leg amputated, and he died at 95 and a half. But they both made their own choices based on all the information that the doctors could give them. And so your example was exactly what happened in my family with the hardening of the arteries. So.
Right. So I think to sum up, knowing what the consequences are, or what the chances are, and making choices for what you understand quality of life to be, is both a medical ethics question as well as a religious ethics question, right? We're not so dissimilar in terms of what we think. I hope you've enjoyed this. We're going to continue with our honor. A big thanks to Jim and to Darla, who are sponsoring the oneg for this Shabbat. Please join us in the other room. We will do kiddush, we will do motzi, and we will have time to talk with each other and ask more questions if we would like. Shabbat shalom.
That was good. The response was good. That's great. Hey.
this fun all by yourself. It's unacceptable. Where's the box? Oh, there it is. I'll supervise the folding of the. No, you're doing a pretty good job. I'll offer constructive criticism.
That was
Okay, we're gonna leave this here because I don't.
Do you want to steer this in there? You stay.
I don't know about these wires that were. And that goes to the front desk. Okay.
You're welcome. I proved to everybody I can do a service in 30 minutes. Monday, right? Okay, and we'll plan something. The conversion should happen on Tuesday. The conversion should happen on Tuesday, so we'll plan as if it's gone through.
What
And
happened on Tuesdays?
conversion. Anissa's conversion is Tuesday, and then her receiving will be not this Friday, the Friday after. So next time we have services, we have one of these as well as a conversion. Tuesday is her Beit Din. So, assuming everything goes well, which it should, I never like to make the arrangements until after it's been done, but it should be it should be fine. That's okay.
Sunday the 21st, and then you're leaving till Monday the 22nd.
It's going to be, I think this service worked well. It was 35 minutes. The next one's going to be a little bit longer. Correct. Yeah, that's not going to work. We'll meet on Monday. We'll meet Monday. I will try to get up. You're used to seeing me groggy. Everything's put back except the stuff that has to go to my office and be put away. Yeah, I think it's got to the stage we always struggle. Let's have a box of extension cords.
That's all I'm gonna do. I mean, in the distance, I'll get a couple of different sizes so we can. My guess is the largest we use is probably 12 to 15 feet.
It's so ridiculous that like this has been going on for as long as I've been here 5 years. We just need to buy some extension cords and put them in a box and maybe put a label on them.